Thank you very much for the invite. Thank you, Khalid. Welcome, everybody. So it's going to be hopefully just a quick 7-8 minutes presentation from myself to convince you that we should always use post-PCI against Faisal, who's going to say never use it.
اسمح لي دقيقة دكتور حسام دكتور أزعجتونا تراك. Have a seat. Sorry.
The objective from this 7 minutes talk is going to be discussing a case, and through the case we'll define what's successful PCI, what's post-PCI physiology in relation to clinical outcome, discuss some of the reasons for suboptimal result, and then answer the question at the end, and hopefully I will win. Our patient 57, hypertension, dyslipidemia, typical patient coming with CCS class 2 to 3 angina on medical therapy, preserved LVEF, MPI positive in the mid-LAD. The angiography shows a complex long lesion in the LAD, and I did the IFR because I was planning to do the IFR post as well. As you can see, it's a complex lesion with 360 calcification, very highly positive physiology up front. We did a lot of work to decalcify this calcification, and then we get a very nice result with a 3/33 drug-eluting stent at a high pressure. We thought that we had a very successful PCI angiographically, and the definition from the ACC and AHA is technical success, basically based on angiography of minimal stenosis diameter less than 20% and optimum angiographic result. You may add to that imaging to check adequate expansion or a middle A. And if you have no in-hospital negative outcome, it's considered to be a procedural success. However, clinical success is defined by all of these in addition to the absence of symptoms or signs of ischemia, although the definition doesn't tell us for how long. Hopefully in the future, a successful PCI is going to be a lifetime guarantee, no MACE, and that hopefully coming up. So back to our patient, the stent looks a little bit underexpanded. I went with a 3.5 NC and did good post-dilatation at higher pressure. However, the IFR again to be suboptimal in this case. Angina post-PCI, post-successful PCI is very common and has been all over the years, although procedural success has been better and better, the equipment are better and better. We still have anywhere between 20 to 40% patient become symptomatic in the first year. And we know very well from defined PCI study that residual ischemia does exist up to almost 25% in this particular study. And another study, including ischemia trial, shows up to 30%. Luckily, most of these 25% reasons are related to a focal problem rather than a diffuse problem, and 30% of the time it's before the stent, 30% of the time after the stent, or 1/3 of the time it's within the stent itself. The causes for suboptimal result are, some of them are modifiable and some of them are non-modifiable, unfortunately. Stent endosizing, underexpansion, malopposition or thrombus, edge dissection, all of these are stent related. However, not uncommon, we'll see a hidden lesion by just luminogram that we do. Minor stenosis in the residual stent and diffuse disease as well, and procedural artifacts. There's a very nice algorithm. If you follow, you won't miss the ultimate good result at the end. It's very important that you assess the longitudinal facial analysis with the co-registration if you do have it. If you don't, that like me in our cath lab, then you depend on just the simple longitudinal. And then followed by images, and if you follow the algorithm, you will reach to a good result. So in our patient, to explain the suboptimal result, I did the imaging again and it did show, in spite of post-dilatation, still there are some areas of underexpansion. Went ahead with a larger balloon and we got a very nice result, and that's the value immediately after the stent. However, when I advanced the wire distal to the stent, the result is suboptimal again. And again, we did the longitudinal study and it showed diffuse disease distally that we can't do anything apart from aggressive medical therapy. So non-modifiable causes, including the nature, the diffuse nature of the disease, collateral supply to CTO territory, and muscle bridge as well was very present here. I can't emphasize more about the importance of the use of the pullback to give you an actual continual analysis of what's happening and co-registration if you do have it. The question becomes what's an optimum post-PCI result that we are trying to achieve. I think the best is 1, but nobody probably will be able to achieve 1, and few exceptions. It remains very unknown that which figure is actually considered to be optimum. Most of the FFR studies would accept 90. We had from the defined PCI trial, 95 actually was associated with much lower outcome. However, it's achievable only in 39% of the cases. The values we get usually, they are a bit higher in the RCA and the CIRC, and it's more important, as I said before, to have continuous variable analysis rather than a single point entry. The long-term outcome has been shown in many trials. Johnson has shown 1,000 patients in his study and shows very clearly that the higher tertile has lowest outcome. PCI-defined study or defined PCI study as well shows if you get 95% or more, you have much more associated lower outcome. Not only just the absolute number, but including the delta difference as well. It has been shown that it is treated with lower outcome in terms of MACE. This is just an explanation of the 4 categories that you'll get post-PCI. Post-PCI in ACS is not very well recommended. We don't understand it very well. There is a recent study actually doing post-PCI physiology and STEMI, which surprisingly shows it does affect even the non-culprit lesion. So in summary, in my last minute here, post-PCI physiology definitely can reduce the residual amount of ischemia and identify it easily, and intracardiac physiology can guide further management. Low post-PCI FFR associated with higher adverse event, and post-PCI physiology would better define successful PCI, and it's time for us to transition from routine PCI to precision PCI, and I do advocate for combined physiology and imaging because I do believe they are complementary to each other. So to answer the question, yes, I always do it in these following scenario. If you have done it before the procedure, then you might as well do it. Don't be too lazy not to do it. Complex lesion for sure, LAD, left main for sure, severely calcific lesion. Focal lesion, RCA, I would do it only sometimes, and never as always never. Correct, Faisal? Thank you very much.